Everyone, welcome to researchmd.com. We got a great topic today. We're going to teach you everything about gout under 9 minutes. All of our reviews are done. We know how important your time is. 9-minute precise review with all the facts. And please repeatedly watch the video. Repetition is the key for the memory, okay? There's no point in watching a 1 hour, 2 hour long video and if you cannot remember next few weeks or whatever. So just start with, we'll start with our presentation today. Gout, again, my name is Pramil, Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents on a daily basis. I'm also director of research. Let's get into our topic today. Definition: it's a chronic disease, okay? Recurrent attack, severe pain, swelling due to inflammation of monosodium urate crystal. Remember, monosodium urate crystal. And it can form tophi and it can destruct your joints. Epidemiology: higher in men, 2 to 6 times higher, increased with age. Remember that. And the risk factors: hyperuricemia is the main risk factor, typically defined as serum urate concentration greater than 6.8, red meat, seafood, alcohol, definitely beer, and then medication: diuretic, cyclosporin, beta blocker, pyrazinamide, ritonavir, low-dose aspirin, theophylline, all that can cause. When you talk about the pathogenesis, the uric acid, remember, is a metabolic product of purine catabolism. As the level of uric acid increases, there is supersaturation, crystal formation, especially when the serum urate concentration are around 6.8 and the physiological pH and the temperature, and then gout flare occurs due to the acute inflammatory response because of this uric acid crystals deposition in the joint. Time between the flare is referred to as intercritical period, during which a low-grade synovitis may be there, and then you develop chronic gouty arthritis, and finally the tophi and the joint destruction, okay? So there's actually, like, if you look at it, there's 4 stages of disease progression. One is asymptomatic, okay? The urate crystals begin to deposit, and then you got acute gout, severe pain, erythema, the usual symptoms, self-limited. Usually, like, I think, remember, a gouty attack should be resolved in 7 to 14 days, okay? And acute bursitis, tenosynovitis also kind of on. Then you have this, we talk about the intercritical interval gout where the synovitis happen. And then finally this chronic tophaceous gout. Usually take many years to progress. Now, when you look at the signs and symptoms, you always look for the swollen, erythematous, warm, painful joint during the attack. Usually involve the first meta-MTP joint, remember, first MTP joint, okay? Joint, so upper limb may be involved in recurrent flare. Signs of synovitis, bursitis is going to be there. Asymmetric joint involvement. Remember, rheumatoid arthritis is symmetric, but in this, asymmetric joint involvement is common. And the skin changes. You got soft tissue erythema, warmth, swelling, skin discoloration can be seen. So you got this nice prediction algorithm determining the likelihood of gout using diagnostic clinical rule. Use this. We got a highest likelihood ratio when you have greater than 8 points, likelihood ratio 3.1, and if you have less than 4 points, negative likelihood ratio is 0.02. Okay, it's very, very important to use the clinical decision processing tool. They use acute onset, joint erythema, hypertension, male patient, previous attack, first MTP, that's involved, serum uric acid, and put this point together. Greater than 8 point, you got the likelihood ratio 3.1. That means your odds going to be at least 30% higher. Remember that, okay? So diagnostic lab, serum uric acid sensitivity is 97%, specificity around 28%. It's good to know the statistics, sensitivity, specificity, and all that before we do like unnecessary tests. Synovial fluid analysis, we got the great picture up here about monosodium urate crystal, negative birefringence, okay? I think everybody know that. Look at the sensitivity and specificity, pretty good, right? 84 to 100%. Imaging study, you can do an X-ray, usually advanced, you can pick it up, there's advanced gout. Okay, ultrasound is gaining. I can see within maybe 2-3 years, everybody's using ultrasound to diagnose. The sign, you got the double contour sign because hyperechoic enhancement of the hyaline cartilage surface, okay? Sensitivity is like 46% to 95%, but depends upon the the operator. Like, but I think that's going to be the future. Acute treatment, we talk. I mean, you can see like colchicine, followed by high dose NSAID like 5 to 7 days. But be careful when they have renal failure. You can always do prednisone 30 milligram to 40 milligram for 5 days and stop it. There's no need to taper. And if you cannot take oral, always go for the intra-articular injection using triamcinolone is recommended. And then when do you use urate lowering therapy? Okay, so you have to use urate lowering therapy when there is like subcutaneous tophi. Tophi is bad. Okay, it's going to destroy your joint. You have to use urate lowering therapy. Greater than 2 GOUT fairs annually, you have to use it. Even 2 GOUT fairs or greater than 2, you have to use it. Urate arthropathy, renal stone. Okay, 3 classes. First is xanthine oxidase inhibitors like reduce, and then you got uricosuric agent, you got PEGLOTICASE, you got febuxostat. So just look at that xanthine oxidase inhibitor, allopurinol. Start with a low dose, titrate. Okay, but be careful in patient with renal failure. Use only a small dose like 50 milligram. And then you got febuxostat if they cannot tolerate it. You get a black box warning because it can cause like cardiovascular death. Just be careful with that. And then URICOSURIC agent is probenecid. Don't use in chronic kidney disease with a GFR less than 50. And then you got newer drug called PEGLOTICASE, an option which is recurrent gout. And then there's tophaceous gout. You can use it. Serum urate should be checked before and after. You can also, in the complication-wise, complication due to so many complications. One, joint erosion, joint destruction, renal disease, acute kidney injuries, chronic kidney disease, renal stone, and all of those complications. Thank you so much for watching our channels. We'll be back with another presentation soon. Please subscribe to our channel and click the like button, please. Thank you.